Hi, I'm Dr. Jessica Gasser. I am a psychologist from Capstone Behavioral Healthcare in Newton, Iowa. I am going to do a presentation today on a lot of our disorders that we see beginning with a childhood onset or that are most common in children, while also be seen in adults. They just are either starting in childhood age or just most common in children. So we're going to start with these neurodevelopmental disorders. We're going to talk about those. You see here a list of all the diagnoses that are covered in this category, and the ones with asterisks next to them are the ones that I'm going to cover more specifically. But a neurodevelopmental disorder is a diagnosis that starts in the developmental period. So kids usually, we like to say before they start school, we start to see these issues, or we know that they could be present. And the presence of the diagnosis impacts their personal, social, academic, and later on occupational functioning. So that's why they're an area of concern. So we're going to start with talking about intellectual disabilities. A lot of people know this mostly as mental retardation or MR and have called it that in the past. In the newest version of the DSM, which is the DSM-5, it is considered intellectual disability at 4 levels, which are mild, moderate, severe, and profound. So to look at somebody's intellectual disability, we're looking for 2 different areas of functioning. First, we're looking at their intellectual functioning, which is their IQ score. An average IQ is 100, but we consider anything between 90 and 110 to be the average range. So when we do formal IQ testing for somebody, that's what we're really looking and hoping to get, is somewhere between 90 and 110. When somebody has an IQ in the 70s, we consider that borderline intellectual functioning. And if their IQ is 75 or below, or 70 or below more specifically, we're going to start considering a diagnosis of an intellectual disability. Now, a diagnosis in that range does not automatically mean that someone meets criteria for an intellectual disability because, like I said, there's 2 parts. So the second part that we're going to look for are these deficits in adaptive functioning, which means how able a person is to perform tasks of daily living, their hygiene tasks, going to the store, their finances, setting some personal goals for themselves, socializing with others, maintaining school or maintaining work performance, all of those different things. So if somebody has a fairly low IQ as compared to the average score of 90 to 110, and they also really struggle with these deficits in adaptive functioning or their tasks of daily living, we are going to look more closely for a diagnosis of intellectual disability. Now, like I said, we do formal IQ testing to get the IQ score, so we have a kind of a starting point. And we also do some interviews with people who are around the client in question. We take the client's word about what they struggle with and what they do well with, but particularly with people who maybe have a more severe intellectual disability, we're going to look for the people around them, their caregivers, their parents, people who know them well, to give us more information about what that person can and can't do in their daily living so that we have more information about the adaptive functioning piece. So when we're talking about somebody with a mild intellectual disability, we're kind of talking about somebody who might have an IQ right on that border of the 70s range, does okay, can maybe kind of pass with a couple pieces of help a day, and really that's about it. They maintain most of their stuff independently, but they do need a little bit more help than the average person of their age. A moderate intellectual disability is somebody who needs help in more significant areas of functioning, might need more hands-on help, whereas somebody with severe or profound intellectual disability is likely somebody who you won't find living on their own. They will likely have round-the-clock support and supervision and might not be able to complete any tasks of daily living on their own. So with that being said, we're going to then move on to autism spectrum disorder. Lots of times people connect intellectual disability with autism spectrum disorder, but really they're not one and the same. They're kind of 2 separate things, and that's why we want to cover them differently. So autism spectrum disorder, again, is a neurodevelopmental disorder because we see it beginning in children. So we're going to look for functioning issues in several different areas. Particularly, we're going to look for persistent deficits in their social communication skills and how they socially interact across various contexts. The key phrase here is the various contexts piece, because we don't want that they just really struggle to interact with particular group of peers or a particular group of teachers, but really just kind of across the board, even at home, at school, in the community, at different activities, they struggle to really connect with their peers. So sometimes that might mean they just have boundary issues. They don't recognize personal space boundaries or appropriate topics of conversation, things like that. And sometimes it might mean social skills such as not knowing when to stop a conversation, not being able to track a conversation has changed and moved on to a different topic, not knowing what are and are not appropriate topics to talk about. So just kind of connecting with peers in general is very difficult for people with autism spectrum disorder. So that's part one. The second big key of somebody who is diagnosed with autism spectrum disorder is restrictive, repetitive patterns of behavior. So what you're going to see is a lot of motor behavior. Sometimes we see people do a lot of flapping or a lot of wringing of their hands. That's pretty consistent with somebody who might have autism spectrum. They might have very, very, very strict interests in things. So for example, if somebody with autism spectrum has an interest in trains, they're going to kind of work their world around trains, involving trains. Talking about them, being interested in going around them, maybe collecting them, and kind of struggle to see interest in activities outside of that particular topic. And then same thing with activities themselves, very structured, not really coping well with unplanned events or not coping well with any routine changes, things that might be different, people that might be different, foods that might be different, just really struggle to see outside of their personal box. So we're looking for both of those things when we're looking at autism spectrum disorder. And kind of like intellectual disability, there are also severity levels. So level 1 is somebody who requires support. They might need some extra coping in learning new social skills, or support when they're interacting with others, or kind of some supports in their tasks of daily living to try to get them out of their routine, to be more flexible. Somebody with level 2 substantial support might need somebody who's around all the time, might need help more often, might really struggle to ever be able to connect with peers, whereas level 3 is very substantial support, might often need round-the-clock care, or really just the expectation of them improving their social skills enough to kind of have meaningful relationship moving forward is really difficult to see. Same thing with, just to go back to autism spectrum disorder, just like the intellectual disability, we diagnose it using formalized testing. The testing is very specific, and of course the assessor will get information from the child's caregivers or people around them, their teachers, other people to interact with the child to get a picture of what that child looks like in different areas of functioning, different locations, different environments with different groups of people. Okay, so a very hot topic, one that we hear a lot about, and we of course get requests for testing very frequently, is ADHD. In the DSM-4, which was the diagnostic book prior to this one, the criteria had this diagnosis of ADHD split into 2 diagnoses. There was ADD, which was attention deficit disorder, and ADHD, which was attention deficit hyperactive disorder. Now they are combined into one diagnosis, which is just ADHD inattentive type, ADHD hyperactive type, and then of course a combination, which means that we see symptoms of both. And we're going to talk a little bit about which each one looks like in the subsequent slides. We also diagnose this, using formalized testing to include getting somebody's IQ score. Sometimes we'll have parents particularly bring children in and say they're struggling to pay attention in school, or they're struggling to track things and finish homework in school, and we find out their child was just actually low functioning or borderline intellectual functioning, and that might also be why they were having a hard time in school, because they didn't really understand what was going on. So we want to rule that out before we diagnose somebody with ADHD, but also the formalized IQ test gives us some pretty good information and clues about how a child or an adult is able to pay attention to some of the skills that they're being asked to complete and how their inattention might be affecting their cognitive ability overall. So we also want to use it to get some clues about ADHD. We want to make sure that we see symptoms present prior to age 12, that they're present in 2 or more settings, and that they are interfering with functioning. So a lot of times we'll get people who say, yeah, I remember having more energy than most kids or really struggling with inattention, but here's how I coped with it. This is what I learned, and they really figured out how to function well without this attention and concentration issue really affecting them. So we're really looking that it's interfering with functioning in at least 2 or more settings. If the child just struggles at school, we know that maybe there's some behavioral interventions we can put in place at school. Or if they just struggle at home, we know there's things that we can put in place just within the home. So for ADHD, we're looking for it to be across environments. So let's first talk about this inattentive type. Like we said, ADHD inattentive type is not going to be someone who's bouncing off the walls. In fact, looking at them, you might not even know that they're struggling. But this is somebody who really just struggles to pay attention. They make a lot of careless mistakes, and paying attention to something for a long period of time is going to be really hard for them. So they really struggle to follow through on tasks. They might start a lot of tasks and not finish them. They really struggle to organize things. They might be very easily distracted, and so they are going to really avoid activities that are going to take sustained mental effort because they just know themselves halfway through or a quarter of the way through, their brain's going to kind of lose attention, lose motivation. They're never going to finish that task. And so if it's difficult or if it's a long task, they're usually going to avoid it. So if you see up top, this says we're looking for at least 6 symptoms to make this criterion match. So there's, I think, 9 options up here, and we're just looking for 6 of them. And then comparatively, we have ADHD hyperactive type, which is a little bit more consistent with, I think, the media mainstream diagnosis picture. So this is more going to be somebody who's kind of bouncing off the walls. They look like they're kind of being driven by a motor and we can't turn it off. They have difficulty sitting still. They might get up when they're not supposed to, or be running around, blurting things out, talks very fast, difficulty just waiting their turn. They're very impulsive. So this is more of what people think of when they think of ADHD. And because this person's so hyperactive, of course, they have a hard time paying attention, hard time concentrating, and a hard time doing a specific task. Like I said, there's also ADHD combined type, which means that we're going to see 6 or more symptoms in both categories, and that's going to give us a diagnosis of ADHD combined type. While a lot of parents and adults diagnosed with ADHD do choose to treat ADHD through the use of medication, it is certainly not required. There's a lot of self-soothing techniques or mindfulness techniques that somebody can be taught to help themselves improve in their presentation of difficulty with attention or excess energy. And there's also behavioral things that can be put in place both at home and at the school to help a child who has ADHD kind of focus a little bit better. So that's ADHD. Another thing that we see commonly in our practice in children that we wanted to talk about was the presence of specific learning disorders. So a lot of times people will say that their child or a friend or their client has a learning disorder, a learning disability, and really they just mean that they have intellectual disability. So we want to talk about how this is different. Similarly, we know that a lot of schools or a lot of different programming requires somebody to be diagnosed with a specific learning disorder to get certain types of help. So we want to talk about what that means. So, common theme here, this is something we can diagnose with formalized testing. We are going to start with getting an IQ score for them. And remember, the average score for an IQ is anywhere between 90 and 110. So what we're going to do, though, is get their ability level, which is their IQ score, and then compare it to their actual functioning level in specific academic areas. So for example, if somebody's IQ is 100, we expect that their performance in reading, in writing, and math will also be about 100. If we see a statistical significant difference between their ability level and their functioning level, that is when we consider that a specific learning disorder. So the statistically significant difference is 15 points. So somebody's IQ is 100, and their performance level is 84 or below, we can start to consider that a learning disability, and we're going to kind of pay attention to that area. It's got to be for over 6 months, and with intervention not helping. So if the person's really struggling in addition and subtraction, but they've never had a tutor, or they've never had extra help at home from their parents, or they've never stayed late at school to get help from their teacher, they've never gone to the math lab, that's not really going to help us with the diagnosis. Maybe the person's just struggling in that specific area of math. So we want to make sure that other intervention is tried first to see if we can catch that person back up. If that's not the case, parents can bring their child in for specific learning disability testing, learning disorder testing, at which time they'll be given some reading, writing, and math tasks to complete. And then, like I said, we'll compare those two scores to see if there is a deficit. There are 3 specific learning disorders that are identified in the DSM-5, which are reading, writing, and math. The DSM-4 listed some different ones, but right now it's kind of down to 3: reading, writing, and math. So those are the 3 areas that are assessed during formalized testing. And then we just kind of see how we can help the student perform from there. This helps give the teachers a more clear idea about where the person is struggling and how they might need help. But it also breaks down, what specific areas of reading, specific parts of writing, and specific parts of math that the person struggles with. So if they've got some of the basic concepts down, we know that they can build off of that. Or if they're really struggling with phonetic skills, we know that that's a place we need to start for reading and writing, and just provides a lot of information that could help the student kind of adapt to this learning disorder. So those are our neurodevelopmental disorders. And like we said, these are all things that we see starting in childhood, and these are all learning based. So these are all going to particularly affect the child in their learning environment. So now we're going to talk about these disruptive impulse control conduct disorders. And this is more similar to the neurodevelopmental disorder, things that we see problems starting when children are younger. But this is less about learning and cognition and more about behavior. So outward behavior that we see happening. So again, here is our list here of the diagnoses that fall under this category, but the ones with the asterisks are the ones that are going to be covered in this discussion. So we're just going to talk about 3. We're not going to talk about pyromania and kleptomania today, but just oppositional defiant disorder, intermittent explosive disorder, and conduct disorder. These are the ones that we see most common in our practice. So oppositional defiant disorder, you see a lot of people just call it ODD, are behavioral symptoms, acting out behavior in 3 specific areas, not just every once in a while, not just for a couple of weeks, but for over 6 months interaction. The other thing that's very clear and very important about this is that it's with a non-sibling. So we know siblings fight, siblings can get aggressive with one another, siblings can kind of try to get revenge on one another. And unfortunately, that's pretty common in just kind of normal development. So we want to make sure that when we're diagnosing this, we are looking at behavior with people outside of the home. So there's 3 specific areas, angry mood, they lose their temper a lot, they're really easily annoyed, they're super irritable, they're angry, they're super resentful towards other people. Part 2, they're kind of argumentative or defiant, so they argue with authority figures, they don't seem to have a care in the world or respect for authority figures. They actively defy or go against the rules on purpose. They go out of their way to try to annoy people, go out of their way to try to push people's buttons, and then also take no responsibility for their behavior, are very easy to blame others. And then the third piece here is pretty vindictive. So they're blaming others for their mistakes. They're blaming others. On top of that, which kind of gives them this anger towards others. So then they're very spiteful and they really try to get back at people. And whatever that person did, they kind of up the ante to that person, kind of raise the battle a little bit more, and try to make it a bit more severe. We've got 3 levels here of severity: mild, moderate, or severe. Of course, this would increase in severity level based on the aggressiveness of the behavior, the prolongingness of the behavior, and how often we're seeing the behavior. So we're looking for this to be over 6 months. If it's a couple times a week, we might be more in the mild, moderate range. If this is something that's happening a few times a day, every day in several different settings, we're going to be looking more at the severe diagnosis category. So next we've got intermittent explosive disorder, which is behavioral outbursts or just really no control over aggressive impulses towards other people. This can be verbal aggression or physical aggression. And of course, the more severe the aggression, the more severe the level of intermittent explosive disorder. So there's 2 different ways you can diagnose this as far as the timing goes. So the verbal or physical aggression is twice a week for 3 months or more, of course, or 3 major explosive episodes within a 12-month period. So the big piece here is that it's not just aggression, your sibling makes you mad, so you push them, or they hit you, so you kind of shove them back. But it's that the magnitude of the aggression is completely out of proportion to the stressor itself. So we may see things like, your sister wore your shirt, and so you might chase her around the house with a knife. Your sibling broke your toy, so you light some of their toys on fire. Just really above and beyond what the stressor itself was. That is something that could have been handled really easily. The aggression usually isn't premeditated, though. That's why I think it's called intermittent explosive disorder, is that we just kind of feel like it comes out of nowhere for a lot of people. The sister might be sitting at the table doing absolutely nothing, or a classmate might be sitting at their desk doing absolutely nothing, and they're kind of attacked by this classmate or this peer or this sibling, just kind of out of nowhere. And from the outside perspective, it looks like this child was maybe acting just fine, and then just kind of flies off the handle with this behavior when we weren't expecting it. And of course, we have a cutoff of, we want to see ages 6 or older when we're diagnosing this, because kids younger than that are still learning social norms. They're still learning what is and isn't okay. They don't know social rules as well as children who are 6 years old or older are expected to know them. So the final diagnosis I'm going to talk about is conduct disorder, which is repetitive and persistent behavior that is just kind of against social norms, kind of violates the basic rights of others, violates people's boundaries, people's space, and really just has no regard for the rules or the law. They just kind of think they're the exception to the rule or the law, or that they just really don't care and don't want to follow the rule or the law. It's broken down into 4 categories. The first category is aggression to people or animals, which means they bully people, they threaten people, intimidate people. They're into a lot of physical fights, usually ones that they started. They might use weapons pretty frequently, just a really high level of aggression starting pretty early on. The second area is destruction of property. That one's kind of self-explanatory, kind of breaking other people's property, breaking their own property, starting fires deliberately, deliberately destroying people's things, just kind of hurt them intentionally. We see it, happening often, and with more and more valuable things that people care a lot about. The third thing we see is a lot of deceitfulness or theft, breaking into houses, breaking into cars, breaking into buildings, lies, being fairly manipulative to try to get things, stealing things that seem to be very important to others with the intention of hurting them. And then, of course, number 4, serious violation of rules. So staying out at night, sneaking out at night, running away from home, truant from school, cutting class, just knowing that there's a rule and intentionally breaking it because they just feel like it. So that's when we see conduct disorder. We see this hopefully, beginning before the age of 13 to diagnose it, particularly with the cutting school is when we're going to see it. And so we just want to make sure we're paying attention to that when we're looking at the severity of the rule breaking. So that was a lot of diagnoses in a short amount of time. And I know I didn't provide a ton of information on all of them. So of course, you're more than welcome to contact us if you have any further questions, to schedule an appointment, to schedule an assessment or an evaluation. We'd absolutely love to meet with you. We've got a really great staff of psychologists and therapists, and also medication providers, psychiatrists, and psychiatric PAs. We have locations both in Newton and Grinnell. So we'd love to meet with you. If you need anything from us, please let us know. Our numbers are here, and then also my direct email. So you are more than welcome to contact us. Thanks so much for sitting through this presentation. I hope you have a great day.